Ladies and gentlemen, welcome to the Combating Antibiotic Resistance, a focus on improving antibiotic stewardship. Your host for today, Diane McCagg, will now begin.
Good afternoon and welcome to today's webinar presented by Lake Superior Quality Innovation Network. Lake Superior QIN is comprised of three organizations, Empro in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support CMS's service priorities for healthcare quality improvement in each organization's respective state. The slides and recording for today's webinar will be available on our Lake Superior QIN YouTube page within the next week. And also the handouts are available at the events registration login page under events materials. At this time, I'd like to introduce our speaker for today, Dr. Arjun Srinivasan. He's the Associate Director for the Healthcare Associated Infection Programs and the Division of Healthcare Quality Promotion at the CDC's National Center for Emerging Zoonotic Infectious Diseases. In his current role, Dr. Srinivasan leads CDC's work to improve antibiotic prescribing and researches new strategies to eliminate healthcare-associated infections. Arjun previously ran the Healthcare Outbreak Investigation Unit, where he has helped facilities track down bacteria and stop them from infecting other patients. At this time, I would like to turn it over to Dr. Srinivasan. Thank you.
Thank you, and thank you so much, Diane, for giving me the opportunity to be with all of you today and to talk to you about antibiotic stewardship. I know many of you are very actively engaged in efforts to improve antibiotic use in your hospitals as part of the scope of work, in particular in your efforts to combat Clostridium difficile. I'll talk very generally about some of the stuff that we are trying to do at the CDC to help with what you're doing, and I look forward to having the opportunity to hear more from you at the end of the talk of our time together, to hear more from you about the types of things that we can do to help support the important work that you're doing. I have no disclosures. Certainly your presence on this call means that you firmly believe all of the things that are on this slide, that this is an absolutely critical time to improve antibiotic use. We know that overuse and misuse of antibiotics is harming patients. It is driving antibiotic resistance. It is helping make infections untreatable. And this is a problem that we now find ourselves in, where we have patients in our hospitals who have infections that we don't have antibiotics to use to treat them. And we know that we can't drug develop our way out of this bind. The development of new antibiotics is not going to be able to keep pace with the development of resistance. We know that antibiotics are misused. This is true in hospitals. It's true in nursing homes. It's true in outpatient clinics. Our focus today is, of course, on hospitals, but do want to emphasize that this problem is not limited to hospitals. And where you put that number depends on your take of the literature and what literature that you read. But if you look at the studies, it's pretty consistently somewhere between 20 and up to 50% of antibiotics that are used in hospitals are either unnecessary or inappropriate for some other reason. And if you look at the reasons why antibiotics are deemed unnecessary, they generally fall, I think, into three big buckets, at least in this study. Again, right in the middle of this range, 30% in this study of antimicrobial days were unnecessary, and they fell into excessive duration of treatment, misuse of antibiotics to treat non-infectious syndromes, so congestive heart failure being treated with antibiotics, or patients with CHF being given antibiotics, or non-bacterial symptoms, viral infections being treated with antibiotics. And then, of course, the last bucket is the treatment of colonization or contamination. You have a positive culture result. The patient doesn't actually have an infection, but yet antibiotics are still prescribed. We know that antibiotic exposure dramatically increases the risks of resistance, and this is important to note that this is for the individual patient. So this is the risk that is being posed to an individual patient when they're getting an antibiotic. And so I think that's something that's important for us to emphasize, is that this issue of resistance isn't just a societal problem. It's actually a risk to individual patients. And that risk is pretty high. So if you look at these pretty bad organisms, extended spectrum beta-lactamase producing gram-negative, carbapenem-resistant Enterobacteriaceae, organisms that I think we'd all agree are pretty tough or in some cases even impossible to treat. Exposure to antibiotics increases a patient's risk of getting one of these infections by somewhere between 6 and up to 29 times. They're really significant risks. And when we're talking about resistance, we're not talking now about the problem of, oh, I can't use antibiotic A, so I'm going to choose among B, C, or D. This is a situation where neither A, B, C, nor D might be effective. And in particular, when we're talking about carbapenem-resistant Enterobacteriaceae, this is a susceptibility profile of a reasonably typical CRE isolate that was sent to us here at CDC. As you can see, this is an infection where there really aren't good options to treat, for example, say, a bloodstream infection with this particular organism. So this is a really important issue with resistance where we talk about untreatable bacteria that are fortunately rare, but we want definitely to keep it that way. We have, as many of you know, at CDC tried to characterize the human toll of antibiotic resistance in the United States. This is a report that was issued a couple of years ago. And at a high level, what we estimate is that every year in the United States, there are over 2 million infections where a clinician cannot use the first-line therapy to treat the infection because it's resistant. So 2 million times a year that happens. And we estimate that 23,000 patients die because of those resistant infections. We also know that you need to add to that number, of course, Clostridium difficile, which I think, in addition to resistance, is the other really, really big problem that's being driven by the overuse and misuse of antibiotics. We know that antibiotic exposure is the single most important risk factor for the development of Clostridium difficile. It increases that risk by up to 10 times, and importantly, that risk stays elevated for a very long time. So a threefold increased risk out to 60 days. So 90 days after getting a course of antibiotics, a patient is more susceptible to Clostridium difficile. And we know that the overwhelming majority of patients with C. diff have an antibiotic exposure in the 28 days before infection. We certainly recognize that even appropriate prescriptions for antibiotics do incur this risk of Clostridium difficile, but our emphasis is if that 30 to 50% of antibiotic exposures are unnecessary, that is a huge number of patients who are being exposed to risks for Clostridium difficile and are getting Clostridium difficile because of an antibiotic course that they never needed in the first place. Based on data that has been recently published, we do estimate that this is a very big problem in the United States. Nearly 500,000 total C. diff infections every year, with 15,000 attributable deaths to these infections. The majority of these deaths, of course, in the most vulnerable patients, older patients over 65 years old. 2/3 of the cases are healthcare associated, so clearly our efforts to improve antibiotic use within healthcare facilities can dramatically impact that, and they're obviously very, very expensive. Having a better sense of how big this problem is and where this problem is, because as you know, C. diff is now reported to the National Healthcare Safety Network as part of the Inpatient Quality Reporting Program. That's why we need to, those are some of the reasons why we need to improve antibiotic use, but I think framed from the more positive perspective, we need to improve antibiotic use because it improves patients' outcomes and saves us money at the same time. It's one of those very, very rare quality improvement initiatives in healthcare that not only improve outcomes, but it saves money while it's doing it. How does it do that? A couple of lines of evidence that I'll show you. The first, of course, is with C. diff. We know that antibiotic stewardship is a critically important intervention to combat C. diff, and many of you, of course, are working on this very issue. There are enough studies about using stewardship to combat C. diff that there's been a meta-analysis of all of this data, and what they find is that stewardship programs are really powerful in their ability to help reduce Clostridium difficile. C. diff in a multivariate analysis was significantly protective against Clostridium difficile, with more than a 50% reduction in the risk ratio, so a very, very protective benefit from Clostridium difficile. And that protection was strongest in the setting that we're most worried about, in the geriatric setting, where the risks of C. diff and the risks of dying from C. diff are so high. But it's not just data from that meta-analysis that I think is compelling. I think the most compelling evidence is summarized in this slide. This is data from the United Kingdom and England, where they have had a long effort to combat Clostridium difficile, and one of the key interventions that they focused on is improving the use of certain antibiotics that are most strongly associated with Clostridium difficile, so cephalosporins and fluoroquinolones, and also focused in reducing the use of those agents in the patients who are at higher risk from the adverse complications in patients over 65. And what you can see is they have had really dramatic results. They have seen cephalosporin doses and quinolone doses drop by somewhere around 50%. Some of this has been replaced by the use of narrower spectrum agents, but some of it has not been replaced by any other agent. So they've really done a good job at eliminating unnecessary use and shifting people to other narrower spectrum agents. And look what's happened to C. diff over that time. They've had about a 70% reduction in cases of C. diff over the duration of this antibiotic stewardship effort. And this is national data, so they have been able to do that across the country. So really, I think, compelling results. What about the impact on resistance? This is obviously a much more complicated thing to show. We know that the development of antibiotic resistance is complex and multifactorial, but I would argue that there have been a number of good studies which do demonstrate that antibiotic stewardship can have an impact on antibiotic use, and this is one of the very nice ones. This was a look at Pseudomonas aeruginosus, the susceptibilities for broad-spectrum antibiotics before and after implementation of an antibiotic stewardship programs, where restrictions were a key component of that. And as you can see, the susceptibility rates for all of these broad-spectrum agents rose significantly after they implemented their stewardship intervention. So they were actually able to reverse the problem of antibiotic resistance through antibiotic stewardship. And finally, we know that stewardship interventions, stewardship programs can save money. This is a very nice example demonstration of that, both a demonstration of the power of stewardship to save money, but also a cautionary tale. This is data from the University of Maryland, where they implemented a stewardship program around the year 2000 because they were having these dramatic rises in antimicrobial costs, which are shown in the bars. And as you can see, immediately following the start of their stewardship program, they saw a dramatic reduction in antimicrobial costs. And the reduction was on the order of $1 million within a year or two. But costs after that point became flat. The stewardship program was able to do a lot of things that reduced their expenditures on antibiotics. But then things got flat, and so the facility said, well, maybe we don't need this program anymore because it's not continuing to reduce costs. And they stopped the stewardship program, and look what happened. Almost immediately after stopping that program, antibiotic costs began to rise, and within 2 years, they had actually risen by about $1 million. So a clear demonstration of the power of antibiotic stewardship to help preserve healthcare resources. But the most important reason that we need to implement antibiotic stewardship programs in our hospitals is that they help us take better care of our patients. We know that the management of patients with infections in hospitals is becoming increasingly complex, and the input from an expert program is becoming more and more important to helping us provide optimal therapy. And this is an excellent demonstration of that. This is actually a randomized trial where patients were randomized to either getting antibiotics with the input of the antibiotic stewardship program, shown in the gray bars, or to getting whatever it was that the provider wanted to prescribe in the blue bars. And as you can see, the patients who had input from the stewardship program were almost 3 times more likely to get appropriate therapy. But what's much more important is that they were 1.7 times more likely to have their infection cured, and perhaps even most important, they were 80% less likely to have a treatment failure of that infection. So antibiotic stewardship programs help us manage these patients better. They improve patient outcomes in the treatment of infection. We say we need antibiotic stewardship. What does that mean? There are a lot of complex and fancy definitions about antibiotic stewardship, but I think fundamentally what we're talking about is really quite simple. It's ensuring that every patient in every hospital gets an antibiotic only when it's needed. They get the right agent at the right time, at the right dose, for the right duration. How do we make that happen? Well, I think if you look at the literature, studies have pretty consistently shown that the best way to optimize our antibiotic outcomes and optimize our antibiotic use is through the use of a dedicated program to address that issue, an antibiotic stewardship program. And the proven benefits of antibiotic stewardship has led a number of organizations to formally recommend their implementation. And just two examples here. In 2014, the CDC recommended that all hospitals in America implement an antibiotic stewardship program. And the American Hospital Association joined us at that time, recommending antibiotic stewardship programs for hospitals as one of the top 5 interventions to improve resource utilization in U.S. hospitals. But how do we make that happen? We know that hospitals don't all look the same in the United States. Hospitals range in size, they range in the complexity and the type of patients that they're dealing with, and so we can't have a one-size-fits-all solution to antibiotic stewardship in our hospitals. There has to be flexibility in how programs are implemented. But I do think there are certain key elements that have been strongly associated with success, and there are certain elements then that we think every hospital needs to make as part of its stewardship program. In 2014, we did lay out what we think those core elements are, if you will, for hospital antibiotic stewardship programs. And many of you might have seen that this past September, we issued a similar document for what we think stewardship programs could look like in nursing homes, the core elements for antibiotic stewardship programs in nursing homes. So in both of these settings, interestingly, the core elements, the structural elements and the activities are basically the same. We have, in talking with experts and reviewing the literature, there are 7 of these key elements that antibiotic stewardship programs need to have. And some of these, as you'll see, are structural, referring to the infrastructure that needs to be in place, and some of these deal with the things that the program needs to do. On the structural side, there needs to be a leadership commitment from the administration. The C-suite, the hospital leadership, has got to be firmly behind this program. And we know that's true for any quality improvement initiative. If the leadership is not behind it, it's not going to be successful. There needs to be a single leader responsible for outcomes. This can't be something that's diffused to the Pharmacy and Therapeutics Committee. There needs to be one person who is in charge of the program and making sure that it's doing what it needs to do. There needs to be a single pharmacy leader. We know that improving antibiotic use is so heavily dependent on the expertise of pharmacists and pharmacist engagement. We think that there does need to be a pharmacy leader who's engaged with this effort. And then there are the activities, the things the program needs to do. There has to be some type of tracking of use. You can't improve antibiotic use if you don't track it in some way to know if you're making progress. You've got to feed that information back to clinicians and to leadership. You have to have reporting of some type on antibiotic use and resistance. You need to educate providers on use and resistance. And then, of course, there must be specific improvement interventions. There have to be concrete things that are being done in order to improve antibiotic use, either around certain antibiotic agents or around certain infections. The leadership commitment I've emphasized is very, very important. We think there should be a formal expression of support for the stewardship program from the facility. Leadership has to ensure that the people who are tasked with running the program have the time necessary to dedicate to doing this. We know that financial support helps a lot in this area. Where doesn't financial support help? But we also know from examples from facilities that it's not imperative. In some instances, written statements of support, policies, have been very, very effective in aiding antibiotic stewardship programs and doing what they need to do. As I've mentioned, if there does need to be a designated leader, we think there should be one person who's on point for this. Physicians have generally proven to be very effective in this role, a variety of different types of physicians, infectious disease trained physicians have obviously demonstrated their expertise in doing this. In places where they don't have access to infectious disease physicians, we've seen other types, hospitalists, intensivists play that leading role, but that because it's a medical staff function, many people have said that physicians can be very effective in that leadership role. But pharmacy leadership is equally critical. If you don't have pharmacy leadership with that physician leadership, you're not likely to be effective. Some type of tracking needs to be done. You've got to monitor antibiotic use. That helps you find the places where you can intervene to make improvements. It helps you assess the effectiveness of what you're doing. In order to support antibiotic use tracking, as hopefully many of you, if not all of you do know, we have developed the antibiotic use option of the National Healthcare Safety Network, which allows for electronic reporting of antibiotic use to help drive and inform stewardship efforts. There needs to be reporting and education. You need to feed data back on antibiotic use, your process measures, your outcome measures. What are your C. difficile rates? What are your issues with resistance? We know that clinicians, the healthcare community, healthcare providers respond well to data-driven approaches. They want to see data about what they're doing and what they need to do. And ultimately, we need specific interventions. And there are many, many examples of what these interventions are. And people will sometimes ask me, which intervention makes sense for me? What one should I implement? And I think this really needs to be driven by what's going on in your facility. I think you need to pick the interventions that resonate most strongly. If fluoroquinolone use is an area where you see problems and there's an interest in addressing it, then maybe that's where you focus. Maybe it's the treatment of community-acquired pneumonia. Maybe it's urinary tract infections. But it's trying to work with your providing community, looking at your data to make that decision about which intervention makes the most sense for you. The one piece of advice I do give to people is not to bite off too much at any one time. It's a start with a focused intervention and then seek to expand your efforts, because as we know in quality improvement, if we try to do too much at once, we end up not being successful with any of it. Last year, we did survey hospitals in the United States through the annual NHSN facility survey to ask them about their implementation of the CDC core elements. And so we got responses back from over 4,000 acute care hospitals in the United States. And as you can see, the majority of hospitals have in place, by self-report of course, individual elements. So these are for the percentages of implementation for the individual core elements. And it's pleasing to see, it's good to see that the majority of hospitals have implemented individual elements. I'm particularly happy to see that ACT is the one that reaches the highest, so this is implementing specific interventions. But we've also looked then at the implementation of all of the core elements. And when we look at that number, what we find is that about 39% of U.S. hospitals report that they have all of the core elements in place. And why is that important? Well, what our experience from interacting with experts in stewardship and looking at the literature, our experience tells us that just having the action is not going to be very successful if the action is not embedded in a program that can help drive compliance with the action and drive that success. We, in looking at this data, know that there are some factors that are more associated with meeting all of the core elements. So larger hospitals are having more success with this than smaller hospitals, though there are a large number of small hospitals who are finding ways to get this done. Teaching hospitals are more likely to have all 7 of the elements implemented, and those facilities that have leadership support are much more likely to have all 7 elements than those that are not. What was interesting is in this analysis, the hospitals that had written leadership support were slightly more likely than even the ones with salary support to have all of the elements, but leadership support in whatever variety it was strongly associated with having all of the elements. Well, we're at 39% now. We want to get to 100%. So how do we get to all hospitals having stewardship programs that are implementing core elements, but even beyond that, stewardship programs that are achieving good outcomes in driving appropriate antibiotic use? Well, we get there through the same ways that we got to our efforts, our successful efforts to prevent healthcare-associated infections. For example, the example of preventing central line-associated bloodstream infections. We had education and training on the interventions and more specifically on how you implement them. We had measurement. Here we need measurement of total antibiotic use, we need measures of appropriate use, and we need to know the prevalence of stewardship programs. We need research to expand implementation and develop new interventions, and we need national goals and national policies. And let me say a little bit about what we're doing in each of these domains. I've shown you the CDC core elements. That's obviously a central point of our educational effort, but stewardship education is not, of course, purely in the domain of CDC. There are lots of different organizations that are working on this issue, and here's a very nice toolkit, if you haven't seen it, the Antimicrobial Stewardship Toolkit, a compilation of a number of different resources that was led by the American Hospital Association with the participation of a number of different professional societies. As part of our education, our focus, I think, needs to be on reframing how we think about antibiotic stewardship. And I take that page again from our experiences in infection control. Infection control used to be, I think, thought of as the responsibility of the infection preventionist, of the healthcare epidemiologist. But in infection control, we have shifted that frame of thinking to now think that that infection control is really everyone's responsibility. It's the job of the frontline providers to prevent infections. It's the job of the infection preventionists and the healthcare epidemiologists to work on the system and the infrastructure to make those prevention efforts successful. And that's the model we need to apply to antibiotic stewardship. Antibiotic stewardship is the job of everyone who is writing a prescription for antibiotics, not just the job of the stewardship program or infectious disease clinicians. So we need to engage other groups. Hospitalists and intensivists have to be absolutely core partners to what we do because they do a lot of the prescribing in our hospitals. We think bedside nurses have to be engaged as well. They don't write the prescriptions, but they administer every dose of antibiotics. So part of our education has to be engaging these other groups in our stewardship efforts. On the measurement front, we are working very hard with the antibiotic use option to do some risk-adjusted benchmarking. One of the things that's been emphasized to us at CDC is that it would be very, very helpful to have some risk-adjusted benchmarking that we can use for performance improvement for antibiotic use, just like we have risk-adjusted benchmarking for infection rates. We have worked, I'm pleased to report, on such a measure that will be part of the antibiotic use option in the next release of NHSN in early 2016. And what we have developed is a measure called the Standardized Antibiotic Administration Ratio, or SAAR. This is our first attempt at a type of quality improvement measure for antibiotic use, and it's very similar in principle to a measure that you're probably quite familiar with, the Standardized Infection Ratio, or the SAAR ratio that we've become so comfortable with in healthcare-associated infection prevention. The antibiotic ratio, the Standardized Antibiotic Administration Ratio, just like the Standardized Infection Ratio, expresses the outcome, in this case antibiotic use, as an observed antibiotic use compared to a predicted antibiotic use. So a ratio of more than 1 means more than predicted use, less than 1 means less than predicted use. And it's important to emphasize that we've worked with a number of different partners to make this measure most useful for stewardship. We didn't want a bureaucratic measure that didn't help drive stewardship efforts. We really wanted a measure that was going to inform and drive action. What the experts in stewardship have suggested to us is that what we really need is not one single measure, but a variety of different measures. They wanted to see antibiotic use ratios for a number of different patient populations. They didn't want to lump ICUs and wards together necessarily. They wanted to be able to split those out. They also wanted to see use ratios for a number of different groups of antibiotics. And so that is the feedback that we've listened to, and that's what we've produced. We have the ability to calculate these ratios for a number of different patient locations. You can do them for intensive care units. You can do them for wards. And then you can put all of that together if you want to get a hospital-wide measure. And we can do it for both adults and pediatrics because we know those patient populations are very different. We also have a number of different antibiotic categories because the stewardship folks told us, look, we might want to target our interventions at specific groups of agents or at specific infections. So give us data on these agents broken down into different ways. So this is what we have. We have these 5 different categories: broad-spectrum agents, predominantly used for hospital onset or multi-drug resistant bacteria. So this is where the carbapenems, the piperacillin tazobactam, cefepines would end up. Then we have broad-spectrum agents predominantly used for community-acquired infections. So here, ceftriaxone, the quinolones are in this group. We have anti-MRSA agents as their own category. We have agents that are predominantly used for surgical site infection prophylaxis, and then we have one category that does combine everything for an overall look at all antibiotic agents. We have submitted this standardized antibiotic administration ratio for review to the National Quality Forum. We are hoping to get this measure endorsed by the National Quality Forum, and I'm pleased to report that it was approved by the Patient Safety Committee and has now gone forward in the NQF endorsement process. We did ask for approval for this only for public health surveillance and quality improvement. This is not a measure that we are envisioning being part of public reporting or pay for performance at this time. We recognize there's a lot of work that has to happen with this measure before we can think about things like that. But nonetheless, we did think it was important to have this external review from the National Quality Forum of that measure. The measure has gone out for public comment. That comment period recently ended, and we anticipate that this will go before a vote of the full membership of the National Quality Forum sometime later this year. I want to emphasize some very important points about the standardized antibiotic administration ratio. So the SAAR only helps direct stewardship efforts to locations and antibiotics where use appears to deviate from expected use. It doesn't tell you that the use is right or wrong, bad or good. It merely tells you if it's higher than lower than what might be expected. Now, that high use might be perfectly justified. If you have a location where there's a very large population of bone marrow transplant patients, for example, in a particular intensive care unit, your use is going to look high, and that may be perfectly justified. And at the same time, low use might be harming patients. So it only points to high and low use. But another point to point out about this type of risk-adjusted benchmarking measure is that advisors to the President, external advisors to the government have said that there do need to be these types of antibiotic use measures that can eventually become part of inpatient quality reporting. So there have been recommendations that we need to be keeping an eye on this and moving this train in that direction. Well, in addition to measuring overall antibiotic use, you've heard me already mention the importance of trying to assess appropriate antibiotic use, because ultimately that's where we want to be. To really be actionable, measures of total use have to be paired with assessments of appropriate use. We are not trying to indiscriminately reduce antibiotic use. We are trying to reduce inappropriate antibiotic use. A lot of hospitals are moving in that direction. We would love to see more hospitals doing it. We do have some tools that are available to help you if you're interested in doing some assessments of appropriate antibiotic use. We work with a number of external experts to try and develop some audit tools that would help hospitals assess appropriate use. And we have these tools that are available in Word as Word documents, so you could take them and modify them in whatever way works for you on our Get Smart for Healthcare website. And we have tools for assessing urinary tract infections, pneumonia, anti-MRSA agents, and general antibiotic use. And we've used those tools to inform our efforts nationally to try to do some assessments of appropriate antibiotic use. So based on what's in those tools, which are relatively objective, guideline-driven criteria for appropriate use, we took those tools and built some data collection forms that were used as part of the Antibiotic Assessment Point Prevalence Survey and National Antibiotic Use Assessment Survey back in 2011. And what we did as part of a pilot project is there were 36 hospitals that agreed to do this kind of pilot demonstration of seeing if we could assess the appropriateness of antibiotic use using this kind of assessment tool. And what we found is that we certainly are able to identify some situations where I think anyone would agree a little bit more investigation is needed. So, for example, here's urinary tract infection. So we've got 111 patients who have a diagnosed with a urinary tract infection. So the indication for the antibiotic or the notes of the provider said the antibiotic is being prescribed for urinary tract infection. But look at some of these issues here. So in 16% of the cases, there's no urine culture that was ordered before initiating therapy for a urinary tract infection. I think all of us would agree that with rare exceptions, you need to get a urine culture if you're trying to treat a urinary tract infection. In 20% of the instances, the culture was positive, but the patient had no symptoms. So certainly would suggest there might be treatment for asymptomatic bacteriuria, which we know is a big problem. And in a small number of instances, 3%, the culture was negative. And there were no symptoms, but still the notes indicated that antibiotics were being continued to treat a urinary tract infection. So taken together, nearly 40% of the cases where urinary tract infections are being treated, there seemed to be an opportunity to improve that use. This is, I think, a critical time for antibiotic use measurement. We're beginning to take these first ever steps towards national benchmarking for antibiotic use. We know that's a powerful quality improvement tool, but we know we have to be very careful and thoughtful about how we begin to implement that tool. We need a lot more hospitals to join us in this use, to enroll in the antibiotic use option so that we can continue to work with these thought leaders, these experts in the field, folks who are really interested and motivated to make sure that we're getting this measure right. And that is, of course, my transition to the shameless plug for the antibiotic use option. If you are interested in enrolling your hospital, please do let me know. Send me an email. We are happy to do whatever we can to facilitate your enrollment. Let me turn and talk a little bit about the national goals and national policies, because clearly having national goals and policies is a very important part of our successful efforts to reduce healthcare-associated infections, and we now have those same types of national goals and policies for addressing antibiotic resistance, and antibiotic stewardship is a key component of that. Last September, the President issued an executive order to launch this effort to combat antibiotic-resistant bacteria in the United States. In his executive order, President Obama described antibiotic resistance as a national security priority, created a federal task force and an external presidential advisory council to guide him on how we might execute a strategy to combat antibiotic resistance, and he mandated immediate federal action in a number of different areas relevant to resistance, especially antibiotic stewardship. At the same time that he issued this order, he tasked the government with developing a national strategy and a national action plan to combat antibiotic-resistant bacteria, and antibiotic stewardship features very prominently in that. These are some of the highlight goals for what the national goals are by the year 2020. We want to see all states with aggressive stewardship activities in all healthcare settings. All federal facilities are to have robust stewardship programs. The goal is that 95% of hospitals in the United States will be reporting antibiotic use data to the antibiotic use option of NHSN. And most importantly, we have target goals. Nationally, we want to reduce inappropriate use of antibiotics by 20% in inpatient settings and 50% in outpatient settings, and we want to expand research in this area. I think our efforts to combat antibiotic resistance are going to require that we do some new things. In addition to having some new ways of thinking about antibiotic stewardship, at a broader level, we have to take a new approach to addressing antibiotic resistance. And this is something that I think many of you probably heard about because it was the topic of a recent vital signs report from CDC a couple of months ago. We know that healthcare facilities, no healthcare facility is an island. Healthcare facilities are very, very interconnected. Patients move from acute care hospitals to long-term acute care hospitals to nursing homes to outpatient clinics and then maybe back to hospitals. And we know that whenever they move, they take their microorganisms with them. And the movement of these patients is responsible for the transmission of these agents throughout our healthcare system. This is a beautiful illustration of that. This is one outbreak of carbapenem-resistant Enterobacteriaceae in Illinois. And you can see from this diagram that it was ultimately traced back to one long-term acute care hospital shown in the center here, but that one LTAC was thought to be the source of outbreaks in a number of different hospitals. So as these patients moved around, the outbreak moved with them. And so we know that individual efforts within each hospital are critically important, and every hospital, every nursing home, every clinic needs to take action. But we know that those actions will be vastly more effective if they are coordinated between all of these different types of facilities. We call this the idea of a coordinated approach. We know that if we don't do anything, the current state of affairs is demonstrated by that solid blue line on the top. We'll continue to see a rise in the number of antibiotic-resistant infections. But if we can implement this type of coordinated approach, and this is modeled based on experience both in this country and from other countries, we know that if we can implement that type of coordinated approach, we can see a really dramatic reduction in the incidence of these antibiotic-resistant infections. Let me close by saying just a couple of words about some of the things that have happened with antibiotic stewardship over the past year. And from my perspective, I think one of the most exciting was the White House Forum on Antibiotic Stewardship. In June of last year, the White House convened a forum on antibiotic stewardship that brought together more than 100 leading organizations representing all aspects of both human and animal health, not to talk broadly about preventing antibiotic resistance, but to talk specifically about how we can improve antibiotic use. On the healthcare side, there were a variety of different partners that were there, including different facilities, providers, insurance companies, consumers, patient advocates, as well as industry. Additionally, there have been some regulatory steps that have been taken on stewardship already, and there are others that are, of course, being talked about. Many of you saw that this last July, the Center for Medicare and Medicaid Services issued revised conditions of participation requirements for long-term care facilities, and as part of that, they did include that an antibiotic stewardship program must now be part of the infrastructure at all long-term care facilities. And so this is the alterations of the conditions of participation. So it says that if you wish to be paid by CMS, by Medicare, you must comply with these conditions. And a new one now is that you have an antibiotic stewardship program. For long-term care, the stewardship program will be part of the infection prevention and control program. And as I did mention, CDC has developed these core elements for antibiotic stewardship programs in long-term care to help with this implementation. There have been similar discussions about the need for this type of change in conditions of participation, a requirement for stewardship in the hospital setting. It's been put forward for CMS to consider, and so we know that at CMS they have publicly indicated that they are considering that and thinking about what the regulatory changes might be or regulatory measures that can be brought to bear that might help improve antibiotic stewardship. So more to come on that. I will close by saying that I don't think there's ever been a more important or a more exciting time for our efforts to improve antibiotic use for antibiotic stewardship. There's a tremendous amount that's happening right now. And I also know that no single group is going to solve this problem. The challenges posed by antibiotic resistance and the challenges of improving antibiotic use can't be fixed by the government alone. They can't be fixed by individual providers alone, professional societies, insurance companies. All of those different groups have a unique and important part to play in helping solve that problem. What I am eager to hear and to know from you, and we can open this up for some verbal discussion, and we, of course, have the chat function here as well, but I am really eager to know from you what we can do, what can CDC do to support your important work, be it through individual interactions or at a broader level. What are the types of things that are meaningful and helpful to you as you work on improving your antibiotic stewardship efforts, improving antibiotic use to combat Clostridium difficile? And with that, let me turn it back over to Diane so that we can open the discussion and question and answer part of this presentation. Diane?
Yes, thank you, Dr. Srinivasan. At this time, we'd like to pull up the evaluation poll. Levex, could you pull up the evaluation poll? We'd like all our participants to complete that at this time. Also, operator, at this time, could you instruct the participants on how to get into the queue to ask questions or maybe even answer or have a dialogue with Dr. Srinivasan on his questions that he's posed to the hospitals out there?
Certainly. Ladies and gentlemen, at this time, if you would like to ask a question or make a comment, please press star 1. Once again, if you have any questions or comments, please press star 1.
Dr. Srinivasan, while we're waiting, it's Diane over at MPRO. I was interested to know, I know to get the data that you need moving forward on this new acronym, SAAR, they need to be submitting data into NHSN and the antibiotic use option. Do you have a feeling or a sense how many hospitals are currently utilizing that option or that module in NHSN?
Yes, Dan, I have a very good sense. So we know right now that there are 116 hospitals around the country in 29 different states who have submitted data to the antibiotic use option. We know that there are barriers to implementing the option. It's not easy. It's not yet to the point where a lot of the vendors have got this to where you can just do kind of plug and play. We are seeing movement in that direction from a number of the different pharmacy and electronic health record vendors, but we are beginning to see enrollment grow slower than we'd like, slower than anyone would probably like, but we are beginning to see movement in that direction. And we're certainly eager to hear from folks we know what some of these barriers are, but we're always eager to learn from people what the barriers are to getting enrolled so that we can explore ways that we might be able to help overcome some of those barriers.
Yeah, thank you. I think there are barriers related to that, and if people don't feel comfortable today, discussing it on the webinar, they have access to your email, and I'm sure you'd be happy to discuss it further with them.
Always. We've got some really wonderful folks here who have worked with all of the hospitals that have come on board and have a really good sense of how to overcome some of the key barriers. And of course, we know that one of the big barriers is one that's a little bit out of our control, and that is, a lot of this is dependent on some of the pharmacy vendor systems and EHR systems being compatible with the module. But as I said, we have done work to try and promote that and improve that, and I think we are beginning to see some good movement in that direction.
Yeah, thank you. That's so helpful. Operator, do we have any questions in the queue right now?
Yes. Our first one is from Christy. Please go ahead.
Thank you. You already answered my question about large drops into the system instead of entering them singly, but you said that's to come, so thank you.
Once again, ladies and gentlemen, if you would like to ask a question or have a comment, please press star 1. We have no further questions at this time.
Okay. I do see something in the chat from Mary. Hospitals are working very hard to get stewardship implemented, but the physicians are not on board. It might be beneficial for physicians to require education as a CME requirement. Yeah,
so Mary, it's an interesting comment, and obviously I think that experience varies from hospital to hospital. But getting physicians engaged is obviously critically important. You have to have your prescribers be part of this effort. If they're not, you're doomed to failure. And some of this, I think, is a good idea for hospitals to explore, what those different requirements are for physicians. Many of those requirements are set at the hospital level. I know that, for example, the hospital that I attend requires that I do a training on risk management every year. I have to do a training for infection control every year. And my hospital actually does require that I have some training on stewardship. So part of my infection control competency assessment that I have to do every year includes some questions on antibiotic stewardship. So that's the approach that my hospital has taken to do that. That's over at Emory where I have privileges. And so I think there are some things that can be done at the individual hospital level. I think we've talked about, could this become part of licensing requirements for physicians, and there have been states that have talked about doing that. That's obviously a trickier thing to do when you're talking about trying to tie something into licensing requirements. But nonetheless, I think that is something that needs to be explored. But I think there's a lot that we can do within our individual hospitals to make sure that clinicians really are on board.
Thank you. We have a few more questions.
I've got these, and I can go through those. So, what is involved in the voluntary reporting program right now? The AU reporting program. All that's involved is signing up. It's getting your facility enrolled, which means making the electronic connection. The AU option is a 100% electronic submission option, so it does require that IT piece. But that's really all that's involved in getting enrolled. And so if you are interested in learning more of what the technical pieces are, let me know. I can port you to where we have some of those resources on our website, and then, as I said, we're happy to talk more. The next one says, infection preventionists have the responsibility to enter information to NHSN for LTACs. But for, I guess it's general acute care hospitals, who would be entering the SAAR information? That's a really good question. So the SAAR information, the SAAR is actually calculated based on the data that is submitted to the antibiotic use option. So what the antibiotic use option captures is the days of therapy, prescriptions of antibiotics per 1,000 patient days. That's what's captured. And then we take that, much like the infection modules of NHSN capture the number of infections per 1,000 patient days, and then the system turns that into a standardized antibiotic administration ratio, just like NHSN calculates for you your standardized infection ratio. But I think what's really important to emphasize is no one actually has to enter data into the antibiotic use option. The information is extracted completely electronically from the pharmacy information system and from the admission, discharge, and transfer system. So once the initial work of setting up those connections is done, that data is automatically extracted and submitted into NHSN. So this does not require any manual data entry. Next question is ideas on how to motivate leadership in the community to support their hospital to be engaged. I think this is a really important question and something very important that Christy is touching on, which is, as I said, no hospital is an island, right? So it's not just the job of one acute care hospital or one nursing home to work to improve antibiotic use. And what we are beginning to see, are some places where the state or local health department is trying to bring together the clinical leadership in the community to say, look, we have a common problem of antibiotic resistance. And poor use of antibiotics at any one of our facilities is going to detrimentally impact every other one. So my acute care hospital might be doing an amazing job with antibiotic use. But if I take patients from a nursing home where there is a lot of poor use and they have a lot of C. diff or a lot of CRE, then I'm going to suffer the consequences there. And so I think this is a key role that our state and local health departments can play, are playing in a number of places, and I think are beginning to play a larger role. It's trying to get those folks together to help people understand that we really are in the same boat together when we're talking about antibiotic resistance and the need to improve antibiotic use. So that's a really important point that Christy is touching on. Are there any other questions?
We have no further questions on the phone.
And I don't currently see any additional questions in chat, but Dr. Srinivasan was very gracious in putting his email address up there. So I know that if you have any additional questions or concerns or comments, I'm sure he'll be happy to address them. We have no additional questions or additional chat at this time. We want to thank you for joining us today for Combating Antibiotic Resistance, the focus on improving antibiotic use. The slides will be available on our Lake Superior QIN YouTube page within the next week. I want to thank you for joining us today, and a big thank you to Arjun for presenting such wonderful material. Thank you so much.
Thank you, ladies and gentlemen. This concludes your call. You may disconnect at this time.